Yeah.
Yeah. No.
Be careful what you say about it. For a sec, for a minute. Yeah, that, everything okay with that, Shane?
Recorded. Calling the meeting to order. This is the beginning of our funding discussion for fiscal year 26-27. So it's an awesome day. Thank you to our partners who are in the room. We appreciate you all being here. And we've got 4 trustees around the table. We have 2 trustees working remotely. Karen and Chuck Mackett are remote, so help me remember.
I have a little bit of a time constraint on the backside, 10:30. I start getting uncomfortable, since there are 4 of us here, because I've got an appointment that I was able to push back, but I have clients that need me.
Okay, well, we all have people who need us, so we'll get as far as we can.
And I can, with your indulgence, I can send a text, how badly do you need me right now? As we get to that.
Now.
Give that us.
Gotcha, all right. Okay, we're going to start with a discussion around mental health collaborative.
Sure, I'll just, tee that off, and then Dawn's gonna give an update. We're working closely with the Mental Health Collaborative on, updating some of their policies and working through some of the financial changes that they've had. You know, QuickBooks transitions and some other things, and putting policies in place and just making sure that they have systems and processes that are consistent and can be applied to the organization to make sure that we get the best, most accurate financial data, and other data. So Dawn, could you give an update on that, please?
Sure, I can do that. So just to give a little bit of an intro, as part of the district's compliance and monitoring responsibilities, there were some concerns identified related to audit compliance and completion of previously required corrective actions, financial reporting, reconciliation deficiencies, and some retirement plan compliance matters. So consistent with the district's funding agreement requirements and the established compliance process, a notice of non-compliance with potential suspension of payments was issued pending receipt of a comprehensive corrective action plan for the collaborative. So since that notice was sent out to the collaborative's board, actions that were taken include the board chair, the finance committee, the executive committee, and they've all been actively engaged in addressing these identified concerns. So actions that they've completed or initiated include, they have completed and have board approval for their FY 2025 independent audit. They did submit a board approved corrective action plan addressing each area identified by the district on their most recent district audit report. They do have board approval of the revised financial policies and procedures. They have established a finance committee to provide oversight and financial reporting. They have engaged the American Pension Consultants to address delayed retirement plan contributions. They established a separate retirement plan bank account and deposited the previously unremitted contributions. And they're committed to providing a biweekly progress report to the district. So they have accepted the additional district monitoring and reporting requirements. And we have been working very closely with the collaborative and the board chair in communication on all of these issues. So a couple of things that are still in progress is to complete the retirement plan remediation, full implementation of the enhanced financial reporting, reconciliation, and month-end close process. They are engaging to add additional accounting support services. And also the newly adopted policies and internal controls are operating right now as intended. So in reviewing all of the documents that were submitted, the telephone conversations and the meetings that we have had over the last week, I believe they've demonstrated substantial progress to address the deficiencies that were identified. They acknowledge the issues, they approved corrective action, assigned responsibility, and established target completion dates. They are committed to ongoing reporting. And as far as, I'm concerned with the out of compliance letter My opinion is that that could be rescinded. They are in full compliance now with that corrective action plan that was submitted to the district and the steps that have been taken. Of course, the final decision always rests with the trustees, so I will leave that to further discussion amongst you all.
You've got a packet of information.
And I
that was
did,
sent ahead.
I did provide a packet, there was a letter from the board chair, a copy of the corrective action plan, and we do have a draft copy of their audit, we're just waiting for the final copy to be sent over.
Great, thank you. Questions? Comments?
Yeah, Paul, Scott, there may be a distinction that makes no difference. First of all, great work all the way around. I appreciate their response. I appreciate the work that you did and fashioning curative measures. And I should have done it at our last meeting. And I really appreciated the work that you did relative to TCCH. I think these are really good examples of the scope of what we as an organization should be doing in terms of our oversight. And I appreciated that. Are they in progress to get to compliance, or are they actually in compliance? In other words, I realize they're committed to doing the plan. They've accepted the observations that were made and are taking curative action. Just the question is, are they there yet? Or are they on their way there yet?
So they have submitted a formal board approved corrective action plan to the district. So as far as, our requirements in relation to our funding agreement, submitting the, annual financial audit and also doing a corrective action for any audit recommendations, that does put them in compliance at this time with those aspects. With our requirements of our agreement.
I think it's probably, I'd like to make a motion that we accept staff's plan and the agreement by them first of all, and then I think then we can just make a decision about.
By staff, you mean which staff?
We're done. In other words,
Okay.
we approve this.
Yeah.
Okay. So I move that we accept the curative measures outlined in the plan and agreement that Don has presented to us.
Yeah, second that.
Any discussion? Dr. Mackett or Karen?
I'm fine with the findings.
Yeah, I agree with the motion and have no discussion.
Fine, I agree. I was gonna second, but Michael beat me to it.
Any public comment? None? Hearing none, all in favor?
Aye.
Aye.
Any opposed? Thank you. Motion passes.
So the next step would be, we need to take a formal action authorizing you to rescind. I guess the letter indicating that they were non-compliant, so they're in compliant. So what's the distinction, the necessity there in terms of our procedures? Do we need to do something?
I mean, we can officially do something. Normally, when I send a non-compliance letter, it's corrected, before it even gets to this point where it comes to trustees.
Okay,
So,
fair enough.
I mean, as far, as we're concerned, they're in compliance now, so the pending suspension is rescinded.
No funding will be released.
Absolutely, next week when we release all the rest of them.
Great.
Correct.
Thank you.
Thank you.
All right, we'll move forward with our first round of discussion for the funding requests. We've got a pretty comprehensive matrix to work through. A couple of comments though, before we start. I know we all remember this, but I want to say this for everybody, and particularly for our agency partners. This is not a debate about the mission of the organizations or the work that they do. I think we entered this with an understanding that it's all valuable, that our community needs these programs and services. This is about aligning the district's goals with the programs that they are bringing forward to us. And some may not align. We saw that last year, and those are hard decisions to make, but that's what we have been entrusted to do. But I would also encourage anybody who's listening, and each and every one of us, to invest their philanthropic dollars in these organizations. Our communities need them, and that's what charitable giving is all about. What we're doing is a little bit different, a lot different. And I just want us to keep that in mind. It's an evolving process. Give each other grace as we go through the discussion. There are some areas that, I saw that overarching themes that I think we still need to continue to work on. Measurable outcomes, for one. And I don't know if that was because we changed up the application a little bit this year. That's something that we'll, ask for feedback on from our partners. There are some significant funding increases this year, and I was having trouble identifying why there were the funding increases. And there's still a couple of organizations that we're the sole funder for their program. And we've talked about that in years past as well. I want to open it up to the floor if there's any other themes that we want to make sure that we take a look at, or if anybody agrees with anything that I just said, or disagrees, please.
I would just say one thing briefly, the work that the staff has done providing us all the data last
Yes.
year, this year, encounters. But I have to say that I would like one more, and that is patients served. I'm interested in encounters. The definition of encounters is maybe a little variable, but the definition of patients is not. So I think we should have that as well. So for what it's worth, I think that'd be a good addition.
Definition of patients served.
I agree.
The number of unique.
Yeah, because there were a couple I wasn't entirely sure how they were counting an encounter, if they dealt with two issues on the same visit or just whatever. And I may have been overreading some of the information, but having each organization define what their encounter is would be helpful.
This is Michael, I guess we get that on the back end
Yeah,
because
correct.
Mhm.
reimbursement, but still, I think Ellen is right. And the other is the same issue that exists every year. I think there are weaknesses in the way we set it up and ask some questions, so we'll continue to tweak the
Right.
process so that what we're seeing is exactly what we want.
Right.
This is Frank, and understand there's been learning for all of us in this,
Oh, yeah.
because, you know, this is the first year we've had unique patient data, unique patient served, and encounter data. So I think going forward, anyone who applies to us for funding will be far better equipped to update those numbers, you know, when they fill out the application, apply with accurate figures.
And Carrie, this is procedural. Earlier, when I was talking about, I counted the number of us in the room, and my
Mhm.
concern was if I do leave,
Right.
there's only three. So we're not necessarily making any decisions today. So you guys obviously don't need me necessarily unless there's gonna be a decision
Right.
made. So
Right.
I just
Yes. Because we've got until 11 o'clock and we've got, you know, quite a few to
Yeah.
start talking about. Dr. Mackett, were you going to share anything? Did you?
Yeah, my only comment was to make sure that we have the number of unique patients. So I think that's been
Okay,
taken care of.
So if I can just make sure I'm clear on what you're asking for, in the application, there is a place for the agencies to list their unique patients that they're projecting to be seen. Are you, so you want that in the information that I
Yeah.
provide with the data? Okay, that's very easy. But when you said definition, because we did ask for the definition of encounters and that was clear, definition of unique individuals.
Well, the unique patient's a unique patient.
That's what I'm saying.
Yeah.
Okay, when I heard definition, I just wanted to
so
understand.
I didn't hear that.
Okay, I just wanted to make sure. Okay.
I did, and then
Oh,
there's,
you did.
and I can't tell you which one, but there was one in particular when I was reading. I was a little bit concerned, and I may have typed an email to you and neglected to press send because my questions weren't in the group. But that was, so I'll have to go back and take a look and I'll reach out to you. and
Okay,
see
were
what you-
those questions related to the group that's being here today? Because we have another group of question and
Okay.
answers for another set
Okay,
of agencies.
okay,
Didn't want to give you 55 pages to
Right.
look at.
I appreciate that.
before.
okay.
21's
Yeah.
21 was enough. So, and I do apologize. I had hoped to have all the answers at one time, but when we saw the length of the document, I said they're not gonna be able to get through this, so I broke it down, so stay tuned.
Jennifer, this is Dr. Mackett.
Yes.
Another thing I would be interested in, at least in the future, I can't remember the specific proposals, but there were at least one or two that had a dramatic change in the number of patients that they projected to serve. And I would appreciate an explanation for why they think that's going to be so.
Yes, Dr. Mackett, thank you. That was one of the themes that we saw. And again, just to reiterate that, this was the first year, this current year is the first year that they did project their encounters. And as we have seen, that was difficult for many organizations, as we've seen, because they've either drastically underestimated or they've drastically overestimated. So I think this year we'll be more dialed in, and when they had to fill out these applications, it was in January, February. So again, they didn't know where they were even falling 6 months out, let alone a year out. So I think we'll have, this will be year 2 coming up with numbers that we can really hone in on and understand. So I appreciate that. And I do think that we will ask for more explanation when even the budget increases a certain percentage. We'll have more information for you at the front end.
Thank you.
Karen?
I'm good, thank you. You all have asked amazing questions, and I don't think I could come up with any other.
Okay, thank you. Okay, Jenny, you want to get us started?
Yeah, so just to give a brief overview of the funding matrix before we start, I just wanted to let you know that these, the completion of the trustee review process, all funding requests were evaluated and ranked based on several factors, including average score, median score, scoring range, and overall funding requests. So you'll see we broke them down in tiers. Tier 1 was the highest support with an average score of 88 to 91. These were programs that received the strongest overall trustee support and alignment. So they demonstrated broad consensus among all trustees regarding the program effectiveness, community impact, and alignment with funding priorities. Tier 2 was strong support, an average score of 84 to 87. And this was consistently favorable evaluations and ranked immediately below the highest scoring applications. And while support remained strong, these programs generally received slightly lower overall scores than Tier 1. This Tier 3 was program scoring between 80 to 83 and received generally positive evaluations, although scoring varied more widely among trustees. Tier 4, this was the average score of 65 to 79, demonstrated the greatest variation in trustee evaluations and generally received lower average scores. Because of the broader range of opinions among the trustees' evaluations, these applications may require additional discussion and deliberation before funding recommendations are finalized. And that's one of the premises is why we started with Tier 4, because we thought if there's going to be more deliberation and maybe require me to go back to the agencies for further information, we could start now rather than being at the end of our process and having to rush through them. So I've invited all of the agencies to attend either in person or on Zoom for Tier 4. And as we looked among the tiers, we can see that there are several agencies that have programs that fell in other tiers. So we thought we'd start with Tier 4, and if time is allotted, we can talk about the other agency programs that are in other tiers. So you'll see I did break down, I have a second sheet that breaks down Tier 4 alphabetically. And then below that is the agencies with the other programs that are in the different tiers. So on that sheet, you'll see that there's the average score, then there's the median score, and then the high and low score of the trustee evaluation, so you can see where the variation is. The amount of request is in the gray column. That was the amount of their request for that program. And then if trustees made a recommendation as to what they would fund, that is in the column, that's listed in the column, and there's the range of the different amounts that trustees recommended. If there's nothing in that column, it was either fully recommended or there was nothing stated as to a reduction or any other recommended range. So that's an outline of this sheet. So if you want, we can start with the first.
Any questions on what Jenny just said? And thank you, because this has been really helpful for me as I've looked through it, so, I think we're ready to start.
Okay, and again, we have the agencies here, so if there are any questions that, again, if you weren't able to get through the question and answer, I understand that. I do have them here with me, so we might be able to answer questions for you. These were questions or comments that were in your evaluation, as well as some other questions that the staff has come up with to help us understand the program. But they all also here. So if you have any specific questions, Madam Chair, if that's okay.
Absolutely.
Okay,
Absolutely.
all right. The first one is child care resources on their developmental screenings. And you can see that there's a recommendation for the funding between 90,000 to 90,856.
Before you do that, Jennifer, Dr. Mackett, just a question. So are you going through alphabetically?
Yes, and Dr. Mackett, I'm
Okay.
sorry, I didn't realize you weren't gonna be here. Shannon just emailed you the sheet that we're looking at right now, and Karen, you as well.
Oh, okay. All right. I'll
Are you
look.
able to get to your email? I apologize. I wasn't aware that you were gonna not be here in person, so I didn't send it to you ahead of time.
Thank
All
you.
right.
I have all the information.
Okay, great. Thank you.
I'll look for that email.
Okay, so in the packets of the questions and responses from the organizations, Jenny, my assumption is that you copied and pasted the response.
That is correct.
Okay.
Correct. And as you mentioned earlier, the themes that we saw that were missing for trustees to make their evaluations were the outcome measures. So a lot of these questions were, please provide us, how many, well, for instance, childcare resources, the developmental, the first one is, please give us your outcome measures, what percentage of children were identified with delays. We just kind of went through and asked some questions, and then we copied and pasted their response into this form.
Okay, trustees, any questions, what would we like the discussion to be here?
I have a question. And who's there for child care resources? Sorry, I don't see everybody.
Shannon is here and
Okay,
a couple of team members, yes.
Shannon, when did this program start? What year?
Shannon, why don't you come to the table?
Yeah.
Okay, thanks.
Yeah.
Good morning, everybody.
Good
Thank you
morning.
for the opportunity to be here today. We started this program over 10 years ago when we saw that many of the children in our program were not meeting their developmental milestones. So at that time, we were meeting with the parents, having them speak with pediatricians. If pediatricians agreed that some additional services were needed, we then were providing the parents with information of local therapies here in our community where they could take their children. We were helping them make the appointments, aligning their insurance. And we found time after time that the parents could not leave work and get their children to these necessary therapies. So we brought it all onto our campus now, overseen by registered nurse and ensuring that these therapies are happening in line with the plan of care put together by the pediatrician. So Karen, to answer your question, this has been evolving over the last 10 years. We have had a registered nurse on staff since 2017.
Okay, thank you. If you didn't have this program, what would your classrooms look like? What would they feel like? And you know, what has been the greatest over 10 years, the greatest outcome for this program?
We often say at Child Care Resources that all behavior is communication. So when children start having behavior issues in our classroom, we start looking at that child individually, looking again, are they missing something with their developmental milestones? Is there something happening at home? And we're able to kind of dissect that and then decide what that child needs individually. So many times the children need these additional therapies, and without these additional therapies, the children will just continue to fall behind. These services are so critical during the first 5 years because it aligns with the brain development that's happening in the first 5 years. And we know that when these children receive these therapies, research shows that 44% of the children who receive them never need the therapies again. So we are mitigating future healthcare costs as well. The children we are tracking in our program, we're finding that less than 10% of them need these therapies as they are entering kindergarten. So our classrooms would look a lot more chaotic, and the children would not be kindergarten ready, where more than 80% of the children leaving our program are kindergarten ready.
Thank you.
I'm sorry, am I interrupting somebody? The WEIP program, these are all sort of interrelated, it seems to me, developmental screenings and what's the size of that staff? You refer to the WEIP staff.
I don't like the WEIP staff. We call it the WEEP staff, but I like WEIP. We're gonna take it all. WEIP. Yeah, so that department is again overseen by our registered nurse, Tracy Griffiths. We have a case manager on staff, and we have 2 board certified behavioral analysts on staff, and we have half of a person doing some administrative work in that department.
So 5. And 4 of them.
4.5.
4, okay, 4.5. And but the 4 are therapists.
2 are board certified therapists and then a registered nurse. Yes.
3 are.
Yes.
Okay, thank you.
Any other discussion, questions?
Yeah, Shannon, this is Dr. Mackett. Thank you for coming in. A question related to our discussion on unique patients. As I recall, for the developmental screening, there was listed over 2,000 encounters, 2,130, I believe. And for the early intervention, it was over 1,000 encounters, 1,092. But I believe in the description, it said you were caring for 100 or projected to care for 160 unique children. But I also noticed there were 240 adults included. So I just wanted to understand how many interventions per child, how are those encounters billed, and explain to me what's involved with the 240 adults.
Perfect. Thank you, Dr. Mackett. Fantastic question. I'm going to ask Tracy Griffiths to come sit, who actually does the encounters and enters the billing and can describe it better.
Hello. So in terms of the developmental screeners, those, each child is getting 3 different screeners twice per year. So obviously, given that they are children, there's the adult component too, because there's a lot of parent education that comes with that. In terms of early intervention, when we're identifying those issues, we're looking at root cause, future impact, all of those things, and what we can do and what interventions need to take place. In terms of billable encounters, a lot of that goes with care coordination. There's a lot of coordination between myself, the pediatrician, and the interdisciplinary team, always involving parents in that as well. Looking at communication with parents, as Shannon mentioned, our children would not get therapies if they did not take place during the day. So in doing that, we really want to involve parents in that too. We want to make sure that they're being communicated with, they're updated, they know what they can be doing at home and what's happening at school and where we're getting. So there's that piece of involvement in terms of that, with team things. In terms of parent engagement, anything that we do with the children, is going to involve parent engagement, especially when it comes to the behavioral piece, because that is a piece that is super involved. Making sure that, and actually, in terms of American Academy of Pediatrics, they recommend that, they want that family-centered approach. So that is important for us to involve them in that, make sure that they are trained to be an advocate for their children, because it's gonna go way beyond what we can do.
So that's the $240.
Correct, yes, that parent involvement.
How, Paula Scott, how is this distinguishable from, what happens at a pediatrician's office as far as the looking for milestones and that sort of evaluation process?
So I think, in terms of what we are able to screen, because we see these kids on an everyday basis, so looking at overall growth motor, fine motor, all of those things. And it, in terms of like you go to the doctor and the pediatrician does an assessment, it's parent discussion, that type of thing, in terms of relaying milestones being met, that type of thing. We're able to actually see those on an everyday basis, so.
So the 163, get there as part of a filtering process because they show up, they're in the program, behaviors are noted that result in a direction toward these evaluations.
The screeners are wide range, so they are developmental in terms of gross fine motor, all of those types of things, communication. In terms of the behavior, we do do a screener for resilience and that kind of thing, and looking at what's going on with the child, because as Shannon mentioned, behavior has meaning. So in doing that, some of that is parents seeking assistance from us too, seeing things that they're seeing at home and how we can intervene in that.
Other questions?
Yeah, Dr. Backett again. So thank you for that explanation. Just to clarify further, then, so the funding includes encounters for children and the education of the parents, or is it only capturing the encounters with the children?
Both. That encounter, we do a good deal of parent engagement with our families on all levels.
So it does include the adults as well?
Yes.
Okay.
The early intervention program, significant increase in the requests this year, correct? Am I?
No, I think it's down.
Down, okay. Oh, this is year to date, okay, sorry, projected actual. Okay, thank you. Other questions? And we want to talk about also the vision hearing screens, because that's
That is
up
on
one
the
tier.
Yep, tier 3.
And there were no,
There were no recommendations,
no
and they
questions.
did, their 7,500 request this year is down from last year's request of 7,600.
And then Dr. Mackett again, so in the same vein, that was listed to include 160 adults as well?
There's always follow-up with our parents, in terms of the screenings are completed by me, and then that follow-up goes to them. And then that goes on to the pediatrician for them, so they need to be included in that process, yeah.
So again, the same question. So the funding is supporting the vision and hearing screening, or is it funding the screening and the follow-up with the adults?
All of it, yes. There are screenings that take place and as well as follow-up, yes.
Okay. Thank you.
Michael,
Michael Kent, a year ago, we talked about whether or not you might be able to reach out to VNA who does provide these services. I think free of charge to early Head Start and Head Start programs. I don't know if that's an avenue that you knocked on that door to see whether there were assists that could be given either financially or in some cost reduction.
We have continued this year to do the screenings with Tracy as, you know, she's a known face to the children, and it's, you know, she's in the building, she sees them. Also with the screen with the young children, sometimes if they have colds and things like that, there's repeated times to go back and do these screenings. And we're utilizing the equipment that we were able to purchase with funding from the hospital district. In the questions that we returned, I'm happy to reach out to Lundy Fields and talk to him about a possible collaboration if that's something that.
It just made sense last year to have it investigated, so, you know, I'm not married to it. And I wasn't sure that they could provide this, all the aspects of screening that you wanted.
And Paul Westcott, I appreciate your comment. Michael, I as I go through this process, looking at, I look for connectedness. This is not a criticism of any of the entities, because you have your mission, you have your board, your focus, but I think there is a gravitation toward silos that if we stretched out, looking at the services that we want to provide to the community, if we looked at it as a bucket, and we need to look at the best ways to put as much money in that bucket from as many sources as we can, and then use collaboration to maximize the dollars that are in the bucket, I think we're all well served. Yeah, I would like to see this particular area explored, a little more connection to some of the other entities. And I'll compliment you. Maybe I didn't read it as well last year as I did this year. I think I came to a better understanding of these programs that you're describing, and how, with the credentialing of those who were involved, I have a strict constructionist view of the special apps, and having credentialed providers involved is a criteria for me that I look for, and I appreciate the reporting that you've done. And my recollection is at the meeting, our last board meeting, is there some reporting data that you all have that might be helpful for us in this process?
Yes, so we have our WEIP task force just wrapped up, and that report is going to our board of directors on Tuesday. So by Tuesday afternoon, I'm going to be sending it over to Jenny for you to see, which is some recommendations for how this department can expand and also serve children beyond our program in a multitude of ways. To go back to your point about collaboration, I absolutely agree with you. We are not in the business of, if there's another partner out in the community to work with, which would benefit our children, we bring them in. We have about 25 formalized MOUs with different organizations in the community, serving our children throughout our wellness program and our childcare program. For example, we work with Tykes and Teens. They come into our building to provide infant mental health to our children.
So I just follow up a little bit. If you've been doing this for 10 years, where did you get the funding before you came to the district? Because now the district is ICAP, because I agree with Paul, these things are all interrelated. And so I look at it as one big program. And now it looks like we're funding maybe 80% of what your expenditures are. But for a number of years, you got funding. Maybe the program was less in those days.
Yeah, so
I
our
don't know
program for many years was one person. And it has grown over the years as we've identified the needs of the children and the services that need to be happening by childcare staff, childcare resources staff on our campus. So it has grown over the years, and we have been very grateful to the district in helping us pilot some things and get this off the ground. We are constantly looking for additional funders. to fund this program, and it's something we will continue to do.
Yeah, Will, just for what it's worth, when I visited childcare several months ago, I bumped into a kid. Young kid, I don't know what he was, 5 years old, something like that, with hearing aids in. And when he, what I was told, when he came to your organization, he was deaf and nobody knew it. Which is sort of hard for me to believe. But that's the kind of situation that some of these kids come out of. So thank you for what you're doing for the.
Yeah, and that situation, his mom knew there was something going on, they didn't know exactly what it was, but we were able to help get that diagnosis, and then Tracy and her team helped that parent navigate the whole system to be able to get the hearing aids, which involved going to Orlando, Miami, and all of those things too. But so yeah, he received his full set of hearing aids when he was 3 years old, and received speech therapy along the way. And actually his whole 4-year-old class, which is what you saw, wanted to learn sign language as well, so they could speak with him. And he didn't have his hearing aids in.
I thought it was fun when he got too much noise, he took his hearing aids.
Gets tired of mom.
Thank you so much for your time today. Again, if you have any other questions, I'm happy to come back or meet with anyone one-on-one or take a phone call.
Thank you, thank you. Are the trustees ready to make a decision on these 3 requests? Do I hear a motion for,
We're not.
I thought we were gathering
oh,
information.
we're just gathering information?
Is
Okay,
that right?
okay,
That's what I understood.
okay.
And in light of additional information, I think it might be beneficial as well.
That's just what I heard, because when you said you were leaving, there was not gonna be any just final decisions, right? But consensus or?
I just wanted to open it up and see what we got to.
Yeah, I thought maybe we could get at least a consensus, but.
Right, well, that was my,
No,
and
but-
my question was. In that light, in other words, a warm fuzzy cold prickly consensus about things, so yeah.
All right,
Okay, I don't know how to define that, but okay.
Well, I can be good at saying something without saying anything.
Okay, okay, and Madam Chair, is there something you would like me to say as I'm going through? Do you want me to mention, just talk about the amount requested and then the recommended increase?
Yeah.
Okay, because I do have that. Okay.
Well, Can I just make a comment, since I thought we were going to gather information and just help us in this process and make a decision. Part of my process is I like to know within the context of everything. And right now, all the data I got is bit by bit. But what does it aggregate to? What's our millage gonna be? I wanna do it in that context before I make a final decision. So that's why I'm not trying to run away from this. I like child care resources, in fact, every organization we're talking about. And we've supported them to some degree. The question is to what degree? And I wanna do that in the context of the whole picture, which I do not have now.
Okay.
This is Frank. Let me just add that if we look to Alan's question, the approved budget last year, plus the additions the trustees added this year for programming services that came back and asked for some more funding. The year-over-year difference is about 1.8 million. So there's 1.8 million in additional requests beyond what we're expected to spend this year. If you remember last year, it was higher than that. But that's where we are as far as the additional ask. It's 1.8 million.
But it's also in the context of appraised values, which I haven't heard yet. And then trying to put that in the context of the millage. So,
Well, let me help with that a little bit too. So we have right now from the property appraiser's office an estimated gross taxable value. Now, remember, regardless what happens, the vote in November is not going to affect anything for us next year. It's going to be the following year on property tax reform. But we're looking at, if we stay at the same millage, 0.7450, based on the gross taxable value estimate we have, we're going to pick up about $1.2 million from that. So,
And I don't know if Alan is saying this, but I always wondered, should we look at assessed value, what sort of burden we want to create to the taxpayer so that we have a dollar amount and build a budget around that as opposed to stacking up the building blocks of our funding decisions and then, oh, here we are. I prefer the former to the latter.
Me too.
So let's continue discussions on the organization,
Yeah.
because we don't have all the data that, related to property, and we weren't expecting to have that,
Right.
that
Yeah.
budget information, so no shade. So we'll move on with Dynamic Life.
Okay, so Dynamic Life, and we do have George and Mike here. So both of the behavioral health counseling and their scholarship both fell in the same tier. Their request in amount total is 150,000, 25,000 for behavioral health counseling and 125,000 for the scholarship. And you can see that the ranges that the trustees recommended for this, for the behavioral health is somewhere between 20,000 and their request of 25,000. And the range between for the scholarship is starting at 107,700 to their request of 125,000.
Okay, we have information from them.
We do have information from them. We had asked some questions about their outcome measures, so that was provided to you. If you have it, or if you need me to read that, or they are here if you need further information.
Michael?
Just a general comment, and you've heard me say this before, and I, it's never black and white, I'm not the guy who always black and white. But I don't like to be in a position where we're 100% of program funding, even if it's a small program. Good programs, just as Alan said, I love them all. But the smaller of the two, counseling, which is an important piece of what they're doing, I get it. But again, we're 100% of the funding and, that predicated what my suggested payment was, which was at 80%. It may incentivize them to work a little harder. Not that they're not working hard, but to find somebody that can step in and make, a $5,000 difference rather than leave it on the district. And that we're talking about one program, that attitude sort of applies to everybody from Cleveland Clinic down to the smallest.
Yeah.
This is Paul Westcott. Question that I have relates to a few months ago, and that is the residency requirement. Where are we on that? I mean, are the scholarship applicants at the time of application have residency? Was the initial contact that brought them here from outside of the county? There was that scenario I was very uncomfortable with. The idea that the folks from outside the county would come here with a clear intention of participating in the program, but they're not residents when they make that determination and they come here and get here to establish residency to benefit from our tax dollars, which is clearly outside this, if not the letter, the spirit of our funding requirements. Do we know any information that we have in terms of, do we have a feel for what their numbers look like in that regard?
I can comment, and in just my experience in, working with agencies here and any agencies that deal with homelessness or substance misuse, they're considered a resident where they slept the night before, a homeless person. So whether they lived in, Vero Beach or Sebastian or Miami or Alaska, if they slept it here in our county last night, they're considered a resident of Indian River. And that's, what I've been told, how it works, how HMIS works. And that's how, those types of individuals are trapped in our county.
My understanding though, for our policies, don't we have isn't there a window? I thought that we had like a window of sorts.
Policy states that they have to have an address in Indian River County. So a piece of male, any type of.
At the time of
At the
application.
time of applications for our financial assistance.
Okay.
And so as long as they can provide us with a proof that they are at that residence, they are in Indian River County, that is considered eligible criteria.
Correct.
So that's a bigger, I'm not saying this is wrong, it's a bigger question than dynamic life, because we.
Absolutely.
Right,
Yeah.
right,
Correct.
They just happen to be the ones
right,
that
right, exactly. And
got to be in front of us.
and I'm not
Yeah.
saying that it's not an important question, it is, I just wanna make sure it's not just dynamic life.
And for our invoicing, to Shannon, we have we do check all zip codes and addresses that way for the identifier.
Put that in the parking lot, maybe.
Mhm. Yeah, well, that's another discussion, yeah.
I'll make a note of that.
Dr. Mackett or Karen?
Yeah, I just wanted further clarification on the counseling part. How many unique patients were served?
Can you answer that for us? I have some of the questions I answered, but I don't know if it's that one.
I don't have I'm Mike from Dynamic Life. I don't have the copy of the application, in front of me, so I don't remember exact
I don't have
number
unique.
that we went back and forth
Encounters.
with the numbers because we were first requiring to go to behavioral health counseling as part of the scholarship. Then we released that requirement, so, because we didn't want people just going to check the box. And then when they didn't show up, we paid the bill. So we really went back to, let's see who really wants this and who wants this as part of their program, so we went back to voluntary, and those numbers, so the numbers, they constantly change month to month, because you'll get a group of new guys that come in, they're all like, yes, we want a baseline evaluation if I'm where I stand on things. And then a lot of them like, I really need this once a week, and then sometimes we have to go, well, maybe it's every 2 weeks now, in terms of the budgeting and how we're allotting those fees for their mental health counseling.
George Lynch, Director of Dynamic Life. We've also instituted not allowing mental health counseling for the first 30 days, just to make sure that the resident is invested in their stay before we begin to provide free mental health counseling.
Are you able to speak to that, Shannon? Thank you.
Yeah, Dr. Mackett, this is Shannon. Just based on our dashboard data from October 1st to March 31st. So that first 6 months, there were 20 unique individuals for 104 encounters for that program specifically.
So this is Karen Deagle. According to, and are we talking about the behavioral health program or the scholarship number program at this point?
The behavioral health.
Behavioral health. So in the behavioral health, in their proposal, they're saying that their estimated unduplicated clients served would be 306, and the number of total encounters would be the same.
Right. That's why I asked the question.
Yeah.
It wasn't clear, but now I'm hearing it's 20 clients.
And yeah, so there's a big discrepancy between the 306 unduplicated clients. So that's going to have to be, that number is going to have to be verified.
George and Dynamic, we were a little confused at that ourselves, so we'll reach out and get clarification for it.
And if you could do the same on the scholarship program, you said on the scholarship program, you would serve 71 unduplicated clients, and there would be 71 unduplicated encounters as well.
Karen, this is Mike from Dynamic again. One of the things that we look at in terms of who's going to counseling and who's not going to counseling, every time, I think the reason why those numbers look skewed is because there's the person who comes to us and says the difference between encounter and actual patient. So we're including the people who call us and say, a mom who calls and says, That's not, that was not what you're told.
We'll get with you.
We'll get with that, okay.
Cause, yeah, cause looking at, it's distinct encounters is 306 and distinct patients is 306, so it looks like that 306 number belongs in one of those two places, but not both.
Yeah, we were a little confused. We didn't reach out. That's on us, so.
And you can see, this is Dr. Mackett again, you can see from our perspective, it makes a difference if we're paying a couple of $100 for a session or $1,000 for a session, right?
Yeah, absolutely. Thank you.
And the encounters for the scholarship are weekly, is that correct, Shannon?
Yes, so the encounters are weekly up to 16 weeks per individual. So it's possible that with that annualized data, that would be roughly.
Other questions? Okay. Thank you. Uh-huh. All right, we'll move on to Mental Health Association, starting with the drop-in center.
The drop-in center was the first one that was in, or the only one that was in tier 4. And it was recommended fully fund at the $40,000 request. If anyone here from? Yeah. Oh, there you are. Oh, hi, I didn't see you. If you have any questions. And then the other 2 programs that they have are listed in tier 3 and tier 2, which is the Parent and Child Center and the Walk-in Counseling Center, so.
Michael, did you just say that regardless of the scores,
Mhm.
the ratings, everybody suggested?
Nobody recommended
Nobody
any other,
So-
so it was a fully fund.
I don't know that this needs a lot of discussion unless there are programmatic questions or issues we have.
Well, the discussion because it was in tier 4. so-
Yeah, and
Yeah.
the reason I think it is, obviously there was a high score of 100 and then a low score of 54, so it brought the average score down.
And actually just missed being in 3.
Mhm.
Any discussion on this one?
Yeah.
Okay.
Yeah, I do, the med tech. Okay, so this is about the med tech. Sorry, I'm trying to keep up here with.
No.
What about the drop-in
Drop-in
center?
center for mental.
Oh,
health.
drop-in center, sorry. That's why I'm, wait a minute. So when you show that there was no recommendations, I don't think that's stating that we don't want to fund the program. I think there was just no recommendations. I would hate for us as a group to look at this sheet and say, oh, nobody wanted to fund, nobody suggested any funding, so we're not going to. Is that
No,
what I'm hearing?
No.
It's actually perceived the opposite.
Yeah.
Because some
Oh,
of the-
thank you. Okay.
Yeah.
Thank you.
Some who put in their recommendation either said fully fund or they made a recommendation to reduce the funding, but if there's nothing, then it's fully fund.
Okay. Thank you.
Any questions on the 2 programs that were down below that tier 3 was the Parent and Child Center, tier 2 was Walk-in and Counseling Center.
And in your packet that you received, which you may not have been able to review completely, there is some outcome measure information in there that helps with your decision when we get to the final decisions for those programs.
Anything else that we need to know at this time? And again, you might have additional questions once we have a little more time to review the responses.
Yeah.
So,
And-
Michael?
I'll just throw out one piece of information as I did last year. In terms of what, I'm talking about Parent and Child Center, that's what I've got in front of me. In terms of their request at $530,000, I always do at the point I did mine, we had 7 months of data this year. What's that extrapolate out to for this year in 12 months? And that would be 530. So the request sort of is in line with the usage rates for this fiscal year.
To do that for others?
I've done it for others. I'm trying to find,
I do have year-to-date, including up to May 31st, total expenses for each program, if the trustees would like that information, I have that available.
Maybe that's something we send out to everybody afterwards, and that would add to.
okay, I just found the walk-in counseling center. Their request was $565,000. Funding in this current year through 7 months, extrapolated out to 12 was 561, almost $562,000. Have they come to us for an increase?
We actually have a meeting with them.
I was gonna say, I
scheduled
think
next
so.
week. Yes.
Because they'd only been funded at about 500,000 this year, 499 something, so.
Yeah.
But again, the request appears to be in line with where they're at, but we haven't given them extra money yet this year to.
Okay. Let's see, anything else? Karen, Dr. Mackey, anything else on Mental Health Association?
No.
Okay,
No, I'm good.
okay. Should we go skip collaborative and SRA in We Care because we'll have to excuse?
That's probably a good idea.
So
Uh,
because this is just discussion, no voting, I don't believe the conflict of interest
Okay.
needs to be implemented. It's really only if there's a vote that there's
Okay.
going to be a conflict there, so. For this purpose in this meeting, we don't have to have those individuals excused.
Okay, thank you. All right, so let's keep going with Mental Health Collaborative.
Okay. So, the first one listed here is mental health court. And they have requested, 296,400 for medical services. And there was no recommendation as far as, a reduction of any sort.
And this is Frank, let me just chime in on this one. This is the figure that we had been working with the county on. And, you know, that we had talked about, thankfully, the county stepped in, was able to pick up the program. We said we would fund the clinical portion. And that's the number that I committed to them within the limitations of my, commitment to them, that 296.4 for the clinical portion.
Questions? Okay. Paul?
Yeah, good. I'm just looking, in my notes, I haven't looked at the typewritten material in our computer generated material, but I have in parentheses, administrative and clinical services. Does this cover any administrative or is it
Not
just?
at all, 0, 100% clinical services
Services for Mental Health Association and New Horizons.
to provide services.
Yeah,
to folks.
And it's obviously fee for service, so we're.
that is true. That's correct.
Thank you.
Okay, second one for Mental Health Collaborative Connection Mental Health Services.
Yeah, and oops, I lost my sheet. Hold on one second. Oh my, what happens when I take my service? Okay, so, let's see, for the Mental Health Collaborative Connections to Mental Health Services, they requested 310,000. There was a recommendation of 300,000 to their request of 310,000.
Please repeat that.
They requested 310,000 for this year, which is an increase from last year. Their recommendation by trustees was anywhere in the range of 300,000 to their request of 310,000.
Yes, thank you.
Okay, no other questions at this time? All right, next is New Horizons, and we have one in tier 4 and 4 and tier 3,
That's correct.
right?
That's correct, yes. That's all of their services. I think the one that is in tier 4 is the new one that included the children's crisis unit. And this request went up substantially from their request last year because they're basically adding a service for the children that they didn't have in this current fiscal year. So that their request went up substantially to
8,011.1%.
And so I feel it was pertinent that Mr. Jackson be here to kind of explain that request. And I think that speaks to the misunderstanding as far as the program, with the recommendation of 100,000 to 194,647. So if we would like to have.
Yes, would you come to the table?
Yeah.
Good morning,
Good morning.
welcome.
Thank you, thank you. Yes, it's our understanding that that line item could be applied to our 3 inpatient units. So that's our inpatient adult psychiatric unit, our adult detox unit, and our children's inpatient psychiatric units. So we projected an encounter, which is a bed day of, I think, 730 bed days.
Can you explain that, Greg, explain that to the trustees if you could, what a bed day is?
Okay, so
I think that would be helpful.
Definitely, so we have different funding mechanisms. The managing entity, they pay us for a bed day to be available, so that's not on utilization. So they pay us well below the market rate for the bed to be available, because we're essentially like the fire rescue. We need to be available, we need to be fully staffed for whoever shows up. Medicaid commercial insurances, they pay us based on the bed day that's being utilized, us going through the process of getting authorized, showing medical necessity, and basically proving why this person needs this level of care. So we're basically kind of extrapolating that across these 3 different units, projecting utilization and cost to basically make sure we can break even or earn a profit and keep these units open and viable with the proper medical staff, because you still need 24/7 coverage, you still need psychiatrists, nurse practitioners on call in case emergency events occur. So we're well below the market rate for a bed day from all of our peers. And so this is articulating basically an ask of 730 bed days at the commercial, closer to the commercial rate, based on that bed being used and medical necessity being met.
And just overall, across those 3 units, approximately 25,000 bed days exist. So of the 25,000, we're requesting 730 in this application.
Thank you very much.
Michael.
A question, understanding the explanation, what is the negotiated fee for service rate that we would reimburse on next year?
For New Horizons, the inpatient units, their fee for service rate is.
It's 400.
It's
400.
Sorry,
No, they're going up to.
They're requesting 800.
currently it is 400.
Yeah.
Just for context, 400 is extremely low. You can imagine the care it takes to manage a 24-hour, a 1 bed day. It's $400 is.
Well, it's all gonna be largely appropriately medical related, so, if it's almost 800, currently we're only fee for servicing about half of it.
Yeah.
Okay. Well, it's a big step up, that's clear. But
Yeah, I'm
we're getting it.
confused, does this need not have, did you not have this service last year?
We had the service, the barrier is the eligibility criteria. Establishing that this is someone who's a Indian River County resident that showed that letter of residency, and establishing that, okay, they're eligible within the district care system for us to be able to bill. we have plenty of indigent Indian River County residents, but it's really having that system in place of checking that system, seeing if they already have coverage through one of the other providers, or implementing a process to get them coverage while they're on our unit. We also look at high utilizers. So we identify that people who have had 3 or more admissions within the last 6 months. And basically, we have a team of people engaging them to get them eligible for what they should be eligible for, either Medicaid, before Marketplace, but that's changed. So that's really kind of our focus of the high utilizers from Indian River County who have not gone through that eligibility process. We've improved it and focused it on the outpatient side because those are individuals that are showing up on a monthly basis, and then we have people working with them to get those letters. But for the inpatient, because it's a 3 to 5 day stay, it's more challenging to work that process.
Well, okay, I mean, I still don't understand why it's going up 8 times. I mean, it's an amazing increase. And I guess that, you do write down here that Children Crisis Services Unit bed days are planned to increase materially. But that doesn't tell me why or where they're coming from or why they weren't here this year. I just can't put that kind of increase together.
It's really us just wanting to be prepared for different changes that may occur over the last 2 years. Things have drastically changed as far as the availability of beds for children is kind of in the southeast region. So that's really just projecting, all right, what is the actual cost going to be if we start receiving more children?
There's just a little bit additional context here too, in the sense that many children are insured through Medicaid. Okay, that is, and so the reason you haven't seen necessarily New Horizons here about children before is the utilization uninsured has been very low. We think that's may increase. That's really what we're trying to say. And at the same time, we're trying to keep that children unit operating effectively and successfully in an environment where children's units are decreasing, not only closing, but also decreasing in age range served. New Horizons is really the only one of, if not the only, doing age 5 to age 17.
Wow.
This is Karen Deagle. Sorry.
Karen.
So, keeping in mind that this is all being paid per encounter. So if the projected encounters do not happen, we would not be paying the dollars.
Correct.
Correct. Yeah, thank you.
Dr. Mackett?
Yeah.
You're on mute. Okay.
Okay, so you're projecting an increase and you also need more money. Those reimbursement rates are inadequate.
Correct.
Is that right? Okay. All right, thank you.
Well,
Thank you for what you do too.
Okay. Dr. Mackett?
Yeah, sorry, for some reason, my mute button was stuck on the iPad.
Don't take that personal.
Yeah, so I was going to say Karen's comment as well, but I would like to further understand the May increase. Why you believe that is the case, that the number of encounters may increase. So I'd like to see a detailed explanation of why you think it's going to go up so much.
I mean, we've just been talking to various systems partners, just talking about the children's system of care in general. So, like I said, we just want to be prepared for dynamic changes that may occur.
So this is Paula Scott. Is there somebody out there that you're not privileged to talk about right now?
Right.
Okay. Thank you.
Yeah,
So
I
there's
get,
another- So if I'm hearing you correctly, there's a piece of the puzzle out there that may change, you're anticipating it to change, that you can't discuss with us just yet. I respect that, thank you.
Michael.
This is sort of tangential. But you're one of the few folks that we fund that don't do any fundraising. And I know your challenges are plentiful just in providing the operational medical services that you do, but as with all our partners, we want you to take advantage of any opportunities you've got. I don't know if you even got anybody in staff that's charged or taxed with trying to pull in some philanthropic dollars, but I hate seeing none.
Just one thing that maybe we haven't highlighted enough is we are delivering over $2 million of in-kind pharmacy services and drugs to our clients. Okay, and we do that through who we are and working with our pharmacy, which is in and of itself a fair amount of work to do that. But outside of that, understand.
Yeah, just planting the seed.
And Paula Scott, again, it will be helpful if whoever they are allows you to help us know the full scope of what's going on or that may potentially develop. So just between now and October, whatever information we can have, actually earlier than that, but it'll be helpful.
Okay, so that is the tier 4. And then we have, as I said, 4 down in tier 3, case management, psych evals, outpatient, and mobile response team. And we don't have anything because those are tier 2, so we don't have any questions or responses.
Do you want me to go through the amounts there?
Sure.
Okay. Case management, the request was 50,000. There was no other recommended range, so and several said fully. The psych evaluations, the request was 35,000. There was some recommended ranges of 16,600 to their request of 35,000. And let's see, the outpatient was requested at 60,000. There was some recommended ranges of 45,000 to 60,000. And then their mobile response team requested 150,000, and their recommended range was between 110,000 to their request of 150,000.
And if I may just add what to date has been spent in the first 9 months, for case management, they've spent $26,325 of their $56,000 request. But psych evaluations, they're currently over their current budgeted amount for that program. They're at 21,000. For the outpatient is the same, they're about $3,000 over at 48,000. And for the mobile response team, they're about $2,000 over at 102,000. That's 9 months, 8 months, excuse me, into the fiscal year.
So their requested increase in their request from from last year to this year is tracking.
Yeah, and I have the same. 1 month short of you.
Fresh off the press.
so,
Anything else?
yeah, this is Dr. Mackett. I just had a question on those psych evals. What is and maybe Shannon, you can answer this if New Horizons cannot. What is the current rate we're paying per encounter? Because my calculations had it pretty high.
Currently, we are paying a fee-for-service rate of $420 per encounter for psych evals.
Right. And to me, that seemed maybe about double what the commercial rate would be, but maybe I'm wrong about that.
Hey, Dr. Mackett, this is Frank. The reason the rate is exactly, oh, but not double, but 1.5 times what a commercial rate would be with Florida Blue. Is because it's it's inpatient psych. I mean, so there was an, we discussed an adjustment for that. So we can talk a little bit more offline, but that's the reason for the elevated cost per encounter there.
So again, thank you for that, Frank, but it kind of goes to the question that trustee Westcott and I had. I'd like to know if that 1.5 adjustment is a scientific wag or a wag? Do we have some substance behind that?
Now, all I have is that all the medical fee-for-service rates are based off the most recent CMS outpatient physician fee schedule.
Okay.
That's adjusted for our region. So that's the baseline. That's the baseline for everything. And let me just give you a couple more details there.
So we're trying. I'm sorry. So we're trying to extrapolate from that fee scale to what we think it might be inpatient.
Correct. And this is really, me trying to incorporate the level of care, the involvement, the thoroughness of an inpatient psych eval relative to outpatient. And the, from a work RVU perspective and, just adjusting it for that on an inpatient scale, correct?
Okay, thank you.
Other questions at this time? Thank you.
You're welcome.
Appreciate your.
Thank you.
Paul, I want to do a time check with you.
I'm
You're
checking on.
Are
Okay.
you needed?
Well, and I want to do a time check because I think you should be here for number 4, the trustee matters. So I want to make sure that if we need to take a pause, we do that if you're walking.
Thank you.
Senior Resource Association, the first 2 in tier 4 are Meals on Wheels and the Emergency Alert Response. And then down in tier 3 is the Emergency Meals on Wheels.
And if you would like, I just a quick note on their request of the 1,008,280 for the Meals on Wheels. That is their request from last year as well, but if you recall, we did reduce it to the 756,210. So it does look like it's a substantial increase for their budget request from year over year. They did, there were some recommendations from trustees as far as what the range that they are comfortable with, and it's between 471,000 to 756,210, which is the current level they are at this year. And the same goes for the emergency alert response. Again, they requested the full amount from last year, but it was reduced. And so there's a range, recommended range from 56,980 to their request of 161,976, meaning that there was across the board.
Paul Westcott, if we stayed the course of what our decision was last year, what would that number look like?
That, well, this year was at the 75%. We had, it was stated to go to 50% of their request. Yes.
And the request last year was the same as this year, so it would be roughly 500,000.
Yeah.
Michael?
Cut to the chase. Bottom line, I'd like to repeal the decision that we made last year to sunset this program. Of all the funding decisions that we made a year ago, this is the one that I most regretted. I argued a little about not sunsetting the program last year, but in the end, I agreed with that decision. But since then, I've definitely had second thoughts. I think hearing Miranda Hawker remind me about Maslow's hierarchy of needs reminded me food, water, shelter are at the base of that pyramid. My position has just changed about this program, which from my perspective directly provides essential health-related support to many in need. At a minimum, I would like to argue that we don't sunset the program. And that we find a level of continued support, and actually my number was this year's level. Not full funding, but giving them 75% of what they wanted last year and then maintaining it. But I think that was wrong, and I think it's interesting, and I'm sure that you're all aware, within the last 10 days, the hospital has, throughout the Treasure Coast and down into Palm Beach, has committed a significant amount of money, and in the statement that came out, it says clearly, food is medicine. And I think, and I didn't know that then, but I mean, it's sort of where my head has gone to. So that's the position that I took when I passed my information in, but I wanted to state it. I think we started on a path there that we should get off. And I honestly, truly, honestly think that the public would not be upset about us spending $1 million on Meals on Wheels if we put that to them. I think they'd understand. I know we can't do anything about housing. I know they're at the base of the pyramid too. That's not gonna happen. We can't even make a dent, but this is a program that's identified those in need. I think we should rethink where we're at in this.
Thank you. Alan?
Well, I agree with a lot of what Michael said. I think, I thought we already decided that we're not gonna sunset this program. But I'm in favor of supporting Meals on Wheels. The question is to what degree? My number is the low number there, 471,000. I got that because that is roughly half of what they were spending before they got any district support at all. And it replaces the amount of money that I was told by senior resource people they got from the federal government, which was rescinded at the end of COVID. And I think that's a good place for us to be, myself. And then I have asked, and still have not received, answers about numbers of seniors served. Their stated numbers are inconsistent. And I've asked about it, and there's probably a good reason. Part of it is increase in cost. But they say 20% or so is increase in cost. And the numbers are quite different. Now Jenny just nodded her head and said she has the numbers.
Well, I just got a late response from
Oh.
Robin yesterday, and she did ask me to mention that they did underestimate their numbers in their original proposal. The numbers of individuals served was stated at 252. It does jump to 303. And their number of encounters, which is meals.
You're talking about Meals on Wheels?
Yes.
That number was over 500 before we gave them any money, and it went to 800. And then in their proposal this year, it was back at 500 and something. I just can't reconcile these numbers, and I think to be fiscally responsible, I have to be satisfied with that.
Yeah.
But right now, I'm at 471.
Robert?
Oh, there's you.
Yeah. I knew he was here. Thank you, sorry.
Paul Westcott, I'm in agreement with Alan, and I found it interesting that the local Department of Health, while advocating for the program, while the state program has nutrition programs, it was crickets when they were asked if they're funding this entity. One of the things that occurs, to use an analogy, nature abhors a vacuum, okay? We fill a vacuum, and it allows other entities that probably have a mandate to fill the space to not fill the space. And we have a statutory mandate that I think gives us a lane to stay in. While we survived legislative scrutiny a couple of years ago, once we get past the property tax, we're likely going to have the attention of the legislature across the board. So I'm mindful of the longevity of the district and its ability to serve the community, what goes with that is an obligation to make sure that we follow the spirit of the statute that created us and defines our lane. And great program, Meals on Wheels. I mentioned at our last board meeting, my family is my Meals on Wheels for my dad. He is homebound. He would not eat without us. I hand feed him. Okay, well attuned to the need. This is not a heartless decision by any stretch. But we have a statutory mandate that is not in existence for a Cleveland Clinic or anybody else who says food is medicine. Ours is medically directed, a little sharper edge on that point than just food is medicine. So I have a little bit of concern and how far we go that way. And it's not just the local folks that we have to be concerned with, it's the guys that get together once a year in Tallahassee that evaluate the work that we do. So I'm in agreement with Alan, so thank you.
To address, Alan, your concerns about the numbers of people that are served. We have really been working on this report, and I was talking with Jenny yesterday. I really appreciate that you posed those questions to us because we put together, and unfortunately, I was hoping to have this ready so we could have sent it to you yesterday, but lots of questions came up as we were doing this. So I thank you for allowing us the opportunity or giving us the opportunity to really look at how those numbers panned out and what are the variables. So I'm going to ask Gabe to talk a little bit about our findings, about various funding sources that came in and how it affected the number of people that we were actually able to serve.
Sure. So basically, before you all started funding us, COVID hit. So we actually had a lot of COVID funds, as you all know. So when you all came in and started helping us, most of that COVID fund ended. It ended in 2023, which is the year that you all started funding us closer to the $1 million. So for the unduplicated clients, during COVID, we were about 561. 23-24, we did jump up to over 700. With this new proposal that we did relook at the numbers, Alan, and again, just like she said, thank you, because we actually looked at the application. We're like, okay, something happened. It's actually 674 unduplicated clients in total. And then out of those, 303 funded by the hospital district. That is lower than historically, like in 23-24, you all funded about 358. Last year, you funded about 403. Most of that change is in the cost of per meal. Because back in the 24-25 period, our meal contractor, we had to go off to RFP, our contract ended, and those contracts are about 3 to 5 years. So, and they had raised prices, and you all know what's happened to food prices in the last 3 years. So, our total cost to run the program went from 24-25 that we were at 1070 up to the 1250, which is what you're funding us right now.
That's per meal.
And that's per meal. And then for next year, for this proposal, it's 1280. So it's a small increase. And then we'll have to go to RFP again in about 2 years. So that 1280, we'll have a small increase, but meal cost is now put for 3 years.
Okay.
So we will get this to you. We have it actually, and like you said, we were trying to send it yesterday afternoon, but we ran out of time
last night.
6 o'clock, and we're still.
It still doesn't make sense.
Yeah.
So, yeah, we will have that
If
too.
that makes sense to you, I appreciate you.
Yeah. No, I appreciate you for really questioning it because it made us go back.
Dr. Mackett, anything?
Yeah, I was just gonna say to the team, thank you for coming in, that with the reduced funding last year, we've made this point several times, you still got the mission done. And this year, the hospital is providing additional funding as well. So so I assume if we kept our funding at the same level as last year, you are still gonna feed over 600 people.
That is correct.
Right. Okay, thank you.
With that said, yes, we were very successful in replacing the dollars that we lost this year through some fundraising efforts. But it doesn't change the fact that there's still 288 people that are on the wait list, and that wait list grows by 25 people every day. The funding that we're getting from the hospital, the funding that we're getting from Meals on Wheels America is to bring people off of the wait list. So for us, the money that we raised through the tournament last year is helping us to cover the people and maintain the people that we had fed, which is wonderful. But again, we're always trying to get that wait list down and feed people while they're continuing to wait for public funding.
Right. Thank you, Robin.
Okay, anything on the emergency alert response program?
Yeah, give me a second, please.
Yeah, you had some data somewhere that I thought was pretty interesting, that the number of people that actually got treated as a result of the alert. I can't find it right now, but I thought that was impressive.
We actually, this was one of the questions that Jenny posed, that we had 19% of our participants did have an incident. 27% of those went to the hospital and 73% avoided institutional placement, which is wonderful. But yeah, it's great that we're able to help them through this program.
This is Michael. The bottom line, I'm reading my notes to myself. I felt last year, and I don't think I framed it this way, but the district was responsible for getting 233 folks these devices. So we made that decision to sunset this program too. I'm not gonna, I'll beat the drum for Meals on Wheels a lot louder than I do here, but I don't know how many of those initial 233 clients that came on because of our money still have devices. But I feel some sort of basically, I thought maybe we could consider just paying the cost for the monthly service for those folks until they no longer require a device, which basically means till they're gone. I don't know exactly what that number would be. I had Jenny kind of talk to them again about what the rate is. I don't want to pay admin. I don't want to pay anything other than what the monthly cost for those devices is for the people that we put devices around their necks. My bottom line is and I know we're not making decisions today in any of this, but planting the seed again. I'd be open to a discussion about not sunsetting that program for those 233 people and continuing their service, because I think they've come to rely on it. And when 20% of them need it, that just sort of reinforces it. It would get smaller because obviously these folks are elderly and they're going to pass, but that's where my head was on this. So I plant that seed today. So I know we're not making decisions on any of this stuff, but something to think about.
I just want to ask you, how do you feel about, they point out here, there's an additional 288 seniors that need it now that don't have it.
I know that, and I also saw the response that they've given to Jenny, that the board has made a really significant commitment to this particular program. I understand that you're in the business of serving seniors in all ways. I'm a little less inclined to worry about those that aren't. But we opened the door for those folks, and now we're pulling the plug on the service, as it were, although maybe they'll be successful in finding other people to fund it. But that's where my head was.
Okay.
Anybody else? Dr. Mackett?
No, I'm good.
then we'll go down to the emergency Meals on
Thank
Wheels
you. Oh.
program.
Oh, I'm sorry, I didn't realize I thought we were through.
No. Oh, no.
One more.
Okay. Let's see, where is that one? Yeah, here we are.
That's not
Yeah,
a 4.
no, it was a 3.
Okay.
And there were, the request is 85,094, and there were no other recommended ranges, so it was a fully fund.
Which we didn't have any questions on.
Oh, we've done that for years.
Okay.
Yeah, and there were no questions that I
Okay.
saw. Well, one, there was, oh no, that's for emergency
Yeah.
response, sorry.
Yeah. Okay. Dr. Mack, anything on emergency Meals on Wheels?
No, I recommended fully funding that again this year.
Okay. Thank you very much. All right, thank you, Ron.
Thank you.
Thank you all, man. Thank you so much.
Okay.
So to go get Karen.
Dana, how long will we need for the trustee matter?
That I think would only be a handful of minutes.
Okay, all right, so we'll continue on, we'll get through hopefully the Hope for Family Center. I believe, I saw Marty back there.
Yeah, I was just checking to see who was here.
They're asking for funding for 4 programs, and the 4 programs are in tier 4, correct?
That's correct.
Okay, all right.
So their first one was the patient navigator, and their request is 31,319, and that one was no recommended ranges other than the fully fund. The med tech position, their request is 43,086, and there was a recommendation of 30,000, between 30,000 and the request of 43,086. Intake coordinator and case manager, that was a request of the 8,862, and there was no recommendations for reduction, so fully fund. And then the medical transportation, this one was requested at $1,122, and there was question on whether the district should pay for something as the increment so little. There was 2 comments to that. So the range was 0 to the full request of $1,122. And they did have some questions that answered in their packet. A lot of it was related to their outcome measures, the number served, the med tech position.
Between, I had a
Yeah.
question, I was
Med
trying to
tech.
understand the difference between the.
Yeah, the
Yeah.
2 positions, yeah. So there was a lot to read there.
And I need time to read it, so. Any other questions? Dr. Mackett, Karen?
No, I don't have any others.
No,
Okay.
I'm good, thank you.
Okay, we'll take some time to read this one, okay?
Okay. So no questions for
Not,
Marty?
not yet,
Okay,
not yet.
okay.
Sorry.
Thanks for coming.
Take you some time to relax. Okay, next up is We Care, but that's 3 programs, I just want to be cognizant of time, I want to make sure that.
Yeah, we have 17 minutes.
Okay. First one up, the We Care Foundation is the nurse manager, that was the one in tier 4.
That's correct. The request was 36,000. The recommendation range was between 18,000 to the request of 36,000. There were some questions related to how much time the nurse manager spends on those duties, so that's in your packet. The other requests for funding were tier 1 and tier 2. The tier 1 was the ophthalmology support. And there was fully fund, there was no recommendation for reduction of funding there. And then their new program, which fell in tier 2 for the gastroenterology clinic, which, and again, no, 27,000 is their request, and there was no recommendation for reduced funding. If there's any
Any
questions.
additional questions?
Not a question, but this, Michael, but a comment. I noted that, and I know there's a lot of transition and regrouping whatnot going on with the agency, but just from a financial perspective. Their functional expense is 60.1% is going to program service, and that's a little low. I know it's a small program, but I think it's just something that they need to be cognizant of. Which does suggest that nurse manager, who's also the in charge of everything. It's a matter of how time is assigned. Just look at it and make sure that you're not cheating yourself, because I'd hate to see that. We want to see that up at least around 70, and we'd feel much better about it. I'd feel much better about it. I can't speak for you.
And so that was the question I had. So nurse manager and executive director are the same.
Yeah.
Same person.
Okay.
Just, yes,
Okay.
It's
two hats.
yeah. Lots of hats.
Okay, anything about the new program? Because we didn't ask, it looks like we just asked about nurse manager.
Yeah.
So it doesn't sound like we had any questions about the new program this time.
No.
Okay. Dr. Mackey or Karen? Oh, no, yeah, Dr. Mackey, you can talk. I'm so confused.
Yeah, because of the conflict, I didn't score any of those, so I'll
Yeah,
leave it.
okay,
I'm good, thank you.
okay. All right. Hey, let's go ahead and try and do the whole family. Let's see if we can do it. Okay, so whole family, we've got one in tier 4, which is their new program, Bridge Care.
Yeah, and their request was $295,488. There was all different ranges, starting at 100,000 to 290 to the full request. There was several questions related to the costs associated with the rate, if it's, and that's all in there. They did provide a lot of good information on that program. They are here if you have any specific questions related to that. And then there are other programs fall between the 3rd tier and 2nd tier and 1st tier. Do you want me to go down to those next, or do we have any
If we have any questions
On which,
on
Bridge Care, the first one?
yeah, I to me, it just seems very unwieldy. And opens a door that I'm not sure we want to have opened.
Which one are you talking about?
The bridge care, the bridge care. And maybe I missed it. How will this fit into fee for service? I mean, because it's a marginal, what we're doing is we're making up a marginal loss
Right.
between what they're billing a third party and their build rate, as I understand it. And is that build rate usual and customary? Is it akin to our fee for service? And I'm concerned with this particular one that it opens a door that is gonna become a monster. And it's unwieldy for us anyway. So.
This is Karen Deagle, if I could speak to this too. So we as a district have talked about this for many years. The Alice population and how could we cover this type of program? I'm kind of looking at, and maybe we need to have more discussion on this as a pilot project. I agree with you, Paul, that, we get into this and it could open Pandora's box, but we don't even know what's inside the box, of course. And I'd like to see something happen, but should we have more discussion on what this would really look like and go towards more of a pilot program? And it may not be with just whole family. Who knows?
Yeah, if I may, and it may be staff and the finance committee does some exploration in this so that we have more guidance in how these systems will function, how they do function, and how we might be able to contribute to taking care of it. But I'm not prepared to jump into this right now.
And this is Dr. Mackett. To Trustee Westcott's point, if I did the math right, the projection was over 1,500 potentially new patients getting access, and the rate works out to $192 per. And to Trustee Westcott's point, I'd like to know how much other billing would happen. Are we supposed to pay for the entire patient encounter, or are they going to bill in addition to that, et cetera, to his point? And then to Trustee Deagle's point, how do we know that we're going to bring in 1,539 more patients?
Sure, Marie, you want
Yeah,
that?
that number isn't correct, that those are encounters.
That's encounters.
Right, so it's 513 patients.
That's good, correct.
With 3 encounters, and it isn't the bill rate. Oh, just to clarify that. The amount that it's not covering the entire cost. So of course, we're going to bill insurance. And then the difference between the $295 that we receive for uninsured patients currently and the $192 for the underinsured is what we would collect on average for the underinsured bridge care patients.
We talked about this a little bit internally, and just so you know, there's a level of complexity with this sort of arrangement that we have not ventured into. So it's definitely something that if we do want to start serving the Alice population, which is growing, and we do want to develop, I mean, there's all sorts of models. You know, Alan and I have talked about a couple. I mean, to what degree do we want to be looking at, you know, every insurance is going to pay differently, regardless of what your charges are. Every insurance reimbursement is going to be different. There's a copay, co-insurance, all that. You know, it's just a level of complexity that was something I'd want to make sure we talk through.
And so this would be on average.
Understood. Yeah.
Obviously, this would be on average, because of course, insurance going to pay something completely different. There are some programs in the Affordable Care Act that pay virtually nothing. And so in some instances, we're going to receive next to nothing, in other instances, it's going to be higher. So on average, we're saying $192.
Sure.
Is what the difference is.
Michael? Oh, sorry.
I thought that we had entered into basically this kind of situation with the Mental Health Association. They came to us a couple of years ago. And they were asking us to fill that gap. And I thought we agreed to do that.
Well, the gap is clear with a couple of the folks that we work with where, you know, Sunshine PT, you know, we know their Medicaid payment and we make the difference so they can at least receive a reasonable, like a commercial reimbursement. So that's a different structure because we know for every patient.
Right, you know what that rate is.
Yeah.
Okay, versus all of the other.
It's just a little bit different.
No, I agree, and Karen referred to the fact we have often talked about this. We're covering the Alice population in a lot of ways, and the uninsured, this really fits that underinsured. It is new ground, and it's certainly worthy of further exploration, whether through this program or not, but I think there's some discussions to be had there.
Al?
Well, I just wondered, Marie, if you could describe a patient that, and describe the circumstance they're in and what their income is and why they can't get care.
Yeah, so typically, when we looked at this, we pulled the data, the 513 patients are currently on our discount program, and 50% of them are between 0 and 100% of the federal poverty level. So they are essentially the poorest of the poor. I think, you know, for a one-person household, that comes to like $15,900. And for a two-person household, that's $21,000. So these are individuals that may or may not work, but they are really the force of the poor. And so, you know, anecdotally, our providers say to us, you know, essentially, the patients that come to us in this situation will come for a visit and then ask for additional services at the time of that one visit. So maybe they're coming for an acute service, but they've got chronic conditions, their blood pressure's out of control. Now the visit turns into a 45-minute visit because our provider wants to do the same, you know, the right thing. What the provider should be saying is, you know, I'll see you again tomorrow, right? I'll delay the acute visit because now your blood pressure's out of control. Sometimes we have to send them to the hospital because their blood sugar level is out of control. So these patients tend to delay their care and have fewer visits and then try to get all the services at that one visit. So it becomes chaos. And in the end, they end up in the emergency room.
Well, why aren't they already eligible for district support if they meet 0 to 100%?
Because they have some type of insurance.
They have insurance, yeah.
Because they have some kind of insurance, so explain that part.
Yeah.
So,
So a lot of times they have the Affordable Care Act. And so remember, up until this year, there were significant subsidies under the Affordable Care Act, and so the premiums were extremely low. So there are all these people that we count as being insured, however, their co-pays and their deductibles are so high that for all practical purposes, they really cannot afford to come and get primary care or even behavioral health. So
yeah, so my feeling, I'm sympathetic with Paul's concern. But to me, this is a overlooked group that fits right into our mission.
He's further looking into.
So I kind of like Karen's idea of making this like a pilot program. That we go into this slowly, so it doesn't try not to let it get out of control, but if we limited it to people 0 to 100%, that's the poorest of the poor, as you described. So I think it's worth a try myself, but that's where I am.
So it's just to clarify, the 0 to 100% or 50% of the patients that we presented of the 513. So
Okay,
if we
thank
wanted
you.
to try a pilot of 0 to 100%, would be essentially half.
Any additional questions?
This is Karen Deagle speaking. Is it the 0 to 100% of the poverty guideline that we're going after? Isn't it like, and that's kind of Medicaid level, correct, Maria?
And Medicaid is actually higher, you know.
Yeah,
so-
150. I guess
Yeah.
where I'm looking at is I thought that we would be looking at more of the, 200 to 350%. Those are the individuals that, may have insurance, but can't afford that copay kind of scenario. The other ones that the lower amount, the 0 to 150%, they're being taken care of, indigent care, they're being taken care of by Medicaid. Am I wrong in saying that?
No, they do not have Medicaid. This does not include any Medicaid because Medicaid
Okay.
does not have any copay. This is commercial insurance for the most part, or sometimes Medicare when there's no supplement.
Well, if we limited it to our current definition, 0 to 200%,
Yeah.
how many of those people,
That would be 530.
that would be all 500? So
Yes.
they're all meeting the current,
Yes, they are.
yeah, okay.
And they have insurance.
They have insurance, but the insurance, I don't know if you're familiar with the Affordable Care Act, but you can get.
Absolutely.
A bronze plan
Right.
that pays, hospitalization and nothing else.
Right.
You may get one
But they're
annual
catch
visit
up.
for physical
Right.
and that's it.
Okay.
I like that. I like the idea of a pilot, and I think that we need to go down this path, but I just want to be cautious with it. That's all.
I agree with that.
We can work with Marie and just get more information, see how this would fit into, our structure and see what, so we could talk some more about it offline.
Okay. Hey, we got through all those votes. Woo, woo, good job.
1 minute to spare.
There you go. All right, trustee matters, Dana.
So I know from a structure perspective, I'll talk with you. Want to open with a initial comment, Frank?
Sure,
Okay.
sure. So, Dr. Koenig, has needed to locate, due to a, serious family matter. So he needed to relocate back up north, for the foreseeable future.
So in that vein, we have received his resignation from the district. There will be a further discussion proclamation, I think, that Frank is putting together. So this is not intended to be a brief thing due to importance. It's just to make sure we provide all of the notice that's required. So we have gone through per the special act and the statute, provide the governor's office notice of the resignation that has been accepted. And the requirement is to provide this to the public and all the trustees at the next publicly noticed hearing, which was today. So this is the public notice. So this is the first time this is being out. But we just wanted to make sure that that was relayed to everyone today.
Thank you.
Any next steps that we need to be aware of? We're waiting to hear from the governor's office.
Correct. So they have responded back saying they received and accepted the resignation. There hasn't been any further correspondence yet about what may happen. Obviously, there can be appointments. There's the dictation of what would happen if they do appoint, but we don't have any direction from the governor's office yet as to what they intend to do.
I would just ask for thoughts and prayers for Dr. Koenig and his family. I'd request that, please.
Thank you. Agreed.
Karen or Dr. Mack, any comment, question?
No.
Okay.
Well, I just asked, I agree with being concerned about, Bill Cooney. But, when is the deadline for filing for election in November?
Tomorrow. I was gonna say.
Tomorrow.
All right. So somebody's got a couple hours. Other than that,
Get some signatures.
yeah.
Okay.
You just write a check. If I may, with the constitutional amendment and what we may consider speaking into that process, I think we probably at our board meeting ought to have it as an agenda item to discuss exactly what we're gonna do, and for two reasons. One, Florida statute 106.113 does discuss whether whether or not it's appropriate and how we engage in political discussion.
Right.
So we need to make sure we don't. And secondly, I think from a strategic perspective, we really ought to consider it. And I go back and forth on whether I like the proposal or I don't. I still trying to work that out. But if there's cacophony of opposition from special districts to a legislature and a governor and a future governor who are supportive of this, my concern is what happens during the next legislative session. Meaning, okay, folks, you don't understand. We're going to help you understand. Okay, so I think it's more than just whether or not we're in favor of it, but there, we could, those who are opposed to it could win a battle and lose a war. Because the intention that could come as through special districts as a result of a strong pushback, we've got to be mindful of. So I think strategically and legally, we probably ought to explore it. And not that Frank has suggested or done anything wrong, or other words, I just think that we need to be mindful of it and very intentional. Is my point.
Yeah, this is Frank. I sent out an email, hope all the trustees saw it, about giving some guidance, and this is something I work with Dana on, to what trustees can and can't say. As a private citizen, as long as you add a disclaimer that you're not speaking on behalf of as a hospital district trustee, this is your personal opinion. You can cite whatever view you want, but as public officials, we cannot give our opinion whether we think this is a good thing or a bad thing. We can inform, we can educate. I've coordinated with the county. I have the impact financial projections based on the county's numbers. They ran them very quickly. So I know, and I have a sheet when I present the budget on Wednesday. I have a sheet that I'll also hand out that'll show you the impact should this pass in 2000. For us, it'll be 27, 28 and 28, 29. And the impact is not insignificant. But this whole legislative process on this whole topic, special districts have not been mentioned in this discussion as of now, and healthcare has not been mentioned as any part of this discussion. So there's certainly a lot, but I wanted to get an understanding of how the county was approaching this. And so I've been working closely with them and all 67 counties are all mounting a response. Obviously, this is a topic everyone's going to be talking about. So I'm glad you brought it up.
Right, and they have more freedom to do that because they're not gonna have their charters pulled. They're not gonna be nullified. Special districts were clearly created by statute and, 2 or 3 years ago, we were looked at very closely. So I think everybody needs to be thoughtful. And to the extent the association of whatever I've forgotten the name of the organization.
FASD.
Yeah, they need to be mindful of that because they could win the battle and lose a war.
Well, Kate's up there
Kate's there now.
now, yeah, so
She shared a lot of interesting things with me yesterday.
some information for
She'll have a lot to say when she gets back.
Bet you will.
Any public comment? Before we close out. We stand adjourned.
Thank you.
Thank you.
Have a good one all.